This will be the second of two lectures on the reproductive systems. Last time I discussed the male reproductive system. This presentation today will be covering the female reproductive system. And as you have become accustomed, there are a couple of modules that I'd like you to look over on your own. That's 26.8 and 26.9. Those will be the general anatomical structures of the female reproductive system, and also a little bit of 13 on your own, and I'll probably look at that with you here in a moment. So much of what we want to do as we go through the female reproductive system is make some comparisons, contrast, and be thinking about how the male and female reproductive systems are different. So you'll be going through these two sections on your own, the basic reproductive structures and the anatomy of the ovaries, the uterus, and the associated structures. And I'll pick up with meiosis. Now keep in mind, meiosis, this is the same process that makes sperm. However, there's a little bit of a difference here. So we'll talk about the differences in oogenesis, and then we'll move on and review the histology of the fallopian tubes, the uterine tubes. We'll go through the phases of the uterine cycle, as well as discuss the mammary glands, and then we'll finish up with the hormonal regulation of the female reproductive system. And honestly, this is the area that is probably going to be least familiar to you as we go through some of the hormonal regulation. And then we'll talk about just a couple of clinical disorders that are associated with the system. So review the basic ideas of the female reproductive system on your own. Of course, the gonads here are the ovaries, everything else being accessory organs, including the vagina and the uterus. The clitoris and the labia are the external genitalia, everything else is internal. The mammary glands, of course, are producing milk for nourishing. The ovary, a couple of almond-shaped organs, and they are the primary sex organs for the female. There is going to be blood entering into the ovary through the hilum. The hilum is the general structure where everything enters or leaves an organ. And of course, the ovary has three functions, not only to make the gametes, but also to produce hormones. That's similar to the male, but they also release inhibin, and we saw inhibin also in the male, and this is going to be inhibiting FSH production from the anterior pituitary. There are layers of the ovary. There is the initial layer over the ovary is the squamous or cuboidal cells covering the ovary. That's the germinal epithelium, and that's going to be continuous with the visceral peritoneum. And then there's the tunica albuginea. This is going to be a dense connective tissue layer. And then finally, the ovary, like any other solid organ, will have a cortex and a medullary region that's deep to that. Attached to the ovary, of course, is the uterine tube, the uterus, and if you look in the abdominal pelvic cavity, you would see the vesico-uterine pouch. This is going to be formed, sort of a pocket between the uterus and the posterior bladder. There's also a retrouterine pouch. This will be between the uterus and the colon. Of course, the vagina and the external genitalia. All of this part of the female reproductive system, that should all be reviewed. Here is that retrouterine pouch. Let me go back to that. This pouch here between part of the colon and the uterus, and then this pouch in here is the pouch formed between the bladder and the uterus, the vesico-uterine pouch. There's some ligaments that stabilize the ovaries and help attach them to the uterus. There's an ovarian ligament. There's a suspensory ligament. There's a broad ligament. You've seen those before. Just review that anatomy. Okay, so oogenesis is the formation of the egg, and it is going to be quite different in its timing than in the male. So there's going to be the formation of the oocyte, but we're going to see that where it's different than in males, this process of oogenesis is going to begin before birth, will accelerate at puberty, and end at menopause. Whereas for men, for boys, the process does not begin until puberty and then continues kind of steady state There's a slight decline in sperm production with age, but it's not that significant. And so there's quite a difference in the timing of the gamete production, males versus females. Now, unlike also in sperm production, when you think about spermatogenesis, one spermatogonium will result in four equally sized spermatids, which will then undergo spermiogenesis to become mature sperm. The distribution of the egg during oogenesis is quite different in that when that first oogonium splits, it's going to form one, eventually, it's going to form one secondary functional oocyte. And this will be the only product of this process that is going to be useful at all. And then there'll be two or three, I'll show you why that is, polar bodies. And these are going to be non-functional cells, which would likely be, or will simply be disintegrated. And then the ovary will release what is considered a secondary oocyte because the meiosis does not finish until after and if fertilization occurs. And so we don't even call it a mature egg, if you will, until after it has finished meiosis, which only happens after fertilization. So let's go through a few steps here. So first of all, there's the oogonium. These cells are going to be the stem cells, similar to the spermatogonia. They are going to be, in the male, remember we would have mitosis occurring to make another spermatogonium to replace the first one, and the other one, the B cell, would know to go on and make sperm through meiosis. Here, these oogonia are going to complete mitosis before birth. And each oogonium will produce one oogonium and one primary oocyte. That's similar before we would have produced a primary spermatocyte. That primary spermatocyte will then begin meiosis 1. And this is going to happen before birth, somewhere between the 3rd and 7th month. In 105, I think I would refer to it as the 5th month, sort of as an average. But even though this primary oocyte will begin meiosis 1, it'll stop very, very quickly in the first stage called prophase 1. Now, this is the phase in meiosis where there is exchange of genetic material going on. And so literally, those chromosomes where they're crossing over and exchanging genetic material get stuck in that crossing over phase. And they'll be stuck in that phase until puberty. Now, in order to maintain or to keep those primary oocytes protected, we're going to see how there are follicular cells that will wrap around this primary oocyte and protect it until later in life as a follicle. Now, what will happen is that when puberty comes and the hormones start cycling, then there'll be a rising FSH level, follicular stimulating hormone, and as the name suggests, it's going to stimulate a follicle. And we'll see how it's going to set up the ovarian cycle, and we'll see how these primary oocytes are stimulated and begin to complete meiosis 1. Now, this meiosis 1 is going to result in one secondary oocyte and a second cell, which is dysfunctional, called a polar body. Think of it like the poles off on the far edges, right? We have the North Pole and the South Pole. So when this primary oocyte splits and makes two cells, it doesn't split evenly. It's basically going to split the cytoplasm very unevenly so that the secondary oocyte is essentially full size, and then this little polar body is formed. And so it's much smaller and dysfunctional. Then that secondary oocyte is going to start meiosis 2. Again, there will be an unequal separation. And so this is what's happening after puberty, when about 15 or 20 or so of those primary oocytes are chosen. That cell will begin meiosis 2. Now again, it's not even going to finish meiosis 2. It's going to get stuck again and will not finish meiosis 2 until and if it's fertilized. Then it will divide again, and form that mature ovum. Again, it'll be an unequal distribution, so there'll be another polar body formed at this point. It's possible that that first polar body also divides and forms another polar body. So earlier I told you there could be 2 or 3 polar bodies, and it just happens to be that sometimes that first polar body does not divide, sometimes it does. So here's a visual of this. So here is the oogonium, that's the stem cell. Somewhere between the 3rd and 7th month of fetal development, that cell will undergo a division. That will be, and at this point, will form this primary oocyte. That primary oocyte, notice, is still diploid. It's still 2N. It will then undergo meiosis, and here's the difference in males and females. Every one of these oogonia will undergo mitosis, the beginning of meiosis, long before birth. So we get to that what's called the tetrad, and that is where the chromosomes are literally lining up and are going to exchange information. That's what gives us different looking kids, right? Our genes are rearranged so that every egg is different, every sperm is a different combination of our own genetic material, which gives us genetic variation. So here is that primary oocyte splitting. The first polar body, like I said, is dysfunctional. It may or may not form 2 smaller polar bodies. And then the secondary oocyte, as you can see, is quite large, and it's haploid, 1N. And then during the cycles, some of the primary oocytes will move on and become the secondary oocytes, and then they'll be chosen, and again there'll be a splitting of meiosis II. Again, a polar body is formed, and you can see that the egg is getting larger. Okay, if it's fertilized, then it will go on to complete meiosis II. And here are those 3, sometimes only 2, polar bodies that are formed. So again, unlike sperm that are producing 4 equally sized spermatotids that form sperm, the female, one oogonium, is only going to form 1 mature ovum, and really only 1 mature ovum when it has been fertilized. Now, this formation of these oocytes is going to be part of the ovarian cycle, and this is going to involve some rather significant changes in the ovarian follicles. The follicles are basically the egg surrounded by some cells. So I'm just going to show some layers of cells around that, and that's called a follicle. So it's like bubble wrap around this very delicate egg. Now, there were, I don't know, 5 or 6 million or so of these oogonia that began meiosis back in fetal development. By birth, that number we know drops to around 2 million. What we're going to see is that throughout life, there's going to be a reduction in the number of follicles, and this reduction is called atresia. By the time a woman reaches puberty, there's still only about 400,000 of those primordial follicles remaining, and each month, the hormones, FSH, are going to stimulate a number of these follicles. And so we can see that there's a relatively small number of potential eggs to be formed in a woman compared to men who are forming millions of sperm daily. So at the beginning, we have the primordial follicle. This is basically that bubble wrap idea, that we have a primordial follicle, it's in a nested egg or in a little bubble wrap, and this is what is completely inactive, sitting around the cortex of the ovary. It is surrounded by a single layer of cells. So it's a single layer of flat cells, like some burst, if you will, some flattened bubble wrap. And these are going to be outside on the outer portion of the cortex near the tunica albuginea, which is the outer layer. Now again, once puberty begins, several of these primordial follicles will be chosen, and they will become now primary follicles, and they will begin to enlarge, and the cells around the outside will divide. Now this isn't the egg enlarging yet, but this is simply the follicular cells around the outside. They're going to start enlarging and dividing and forming several layers. These follicular cells are now simply called granulosa cells. So the follicular cells were the flattened cells around the egg. Now we have the follicular cells being called granulosa cells. And they're going to form up as they create layers. These layers are going to have names. There's going to be the zona pellucida. This is a very translucent, clear layer that's developing right around the oocyte. And then there'll be theca cells. And theca means box. So these cells are forming a box, if you will, and they are layers that are going around the entire follicle. Now, these thecal cells and the granulosa cells are, in fact, the cells making the estrogen. Think back in the male, what cells were making testosterone, and you recall those were the Leydig cells. So in the male, there are Leydig cells making the testosterone. In the female, we have these thecal and granulosa cells making the estrogen. Now, some of those primary follicles will continue to develop, and they'll become secondary follicles. And as they become secondary follicles, the wall is going to get thicker, and you'll start seeing some fluid. So if you start seeing fluid on the inside, sort of a hollow cavity around a follicle, we'll now call that a secondary follicle. And that fluid is going to be pushing in between and separating the outer and inner layers of the follicle. Now, usually only one of those follicles that begin the developmental journey each month will become the tertiary follicle. Now, this tertiary follicle has three names. It can be called the tertiary. This is also called the mature. And you'll also see the word Graphian. So you'll hear it called tertiary, mature, or Graphian, or mature Graphian. All of them are the same thing. And these are quite large, 15 millimeters in diameter. So that is what, 1.5 centimeters. So we're talking about something that is rather large. There'll be an even larger fluid-filled chamber, and the outer layers will form what's called the corona radiata. This is an outer layer that is only found around this type of that we start to see in this Graphian follicle. Now, this entire Graphian follicle now will be the one that will, in the middle of the ovarian cycle, be released through the process of ovulation. And so at that moment, the tertiary or the mature follicle is released. What it's releasing is considered a secondary oocyte, and it is surrounded by the corona radiata. This marks the follicular phase, the end of the follicular phase, the end of the formation of the follicular follicle, and the start of what's called the luteal phase. Now, the luteal phase, remember what we're making is the corpus luteum, and lute we know means yellow. And so what happens is that those cells that were around on the inside of the ovary, what was left behind after ovulation, will now begin to secrete progesterones and estrogens. And those progesterones are going to send signals down to the uterus saying, hey, I just released an egg, and in a few days, that egg, which might have been fertilized, is going to reach the uterus. And I want the uterus to be as ripe and as ready for implantation as possible. So this progesterone, specifically by the corpus luteum, is going to be sent down to the uterus, preparing for implantation. Now, that corpus luteum will only survive for about 10 to 13 days. And that's sort of a time window for the egg or the embryo to travel down the fallopian tubes and give the embryo a few more days to ensure implantation into the uterine wall. That 10 or 13 days. Now, if fertilization does not occur, the corpus luteum, if the embryo is not formed, the corpus luteum will regress and form the corpus albicans. And the corpus albicans is this, think albino, is sort of this pale, whitish scar tissue that is produced by some fibroblasts and basically mark the degeneration of the corpus luteum. So there's that 12 days. So if after 12 days implantation has not occurred and there was no embryo, then that will bring an end to the corpus luteum. It becomes the corpus albicans, and this will end the end of the ovarian cycle, and now we go back to going back, I should say, to the follicular phase. So let's put this into a picture. So in the cortex of the ovary, there are thousands and thousands and thousands of these primordial follicles. They've been sitting there since before birth. They're surrounded by a simple squamous epithelium. Every month or so, through the follicular phase of the ovarian cycle, some of those primordial follicles will be selected and they will form primary follicles. With this chosen state, there will be cells formed around those simple squamous cells around the outside, will then begin to divide. At that point, we call them granulosa cells, and it will form layers. So you'll have granulosa cells and thecal cells. Now, just a few of those will continue and make it to secondary follicle form, and what you start to see is that there's fluid, this space up in here, there's some fluid being formed. And when you see the fluid, we'll call that a secondary follicle. Now, inside, we still have a primary oocyte, meaning that we're still in meiosis 1. The tertiary follicle is usually the only one that makes it from the beginning. Now, occasionally a second follicle could be released, and twins would be a possibility. Identical twins would be a possibility, but typically only one. And so now you see a much larger fluid-filled antrum. The egg has become much bigger. The cells around it have become thicker, and there's now, let me clean this off, there's now around the egg itself a layer called the corona radiata. This Graafian follicle is the one that will be released upon ovulation. The ovarian wall will rupture, and the egg surrounded by the corona radiata will be released. And here's an actual micrograph of the eruption. What is left behind, all these other granulosa cells and thecal cells, will now become the corpus luteum. The corpus luteum is going to be making some hormones. Those hormones are going to be traveling down to the uterus and telling the uterus, hey, I just released an egg. And if by chance this egg gets fertilized, I need the uterus to be ripe and ready for implantation. So these progesterone hormones are going to assure that the uterus is proliferating and maintaining its layers. And then if that corpus luteum, after about 12 days, it will begin to regress and eventually become the corpus albicans, this white scar tissue that is shown here. Again, that's largely review. Let's talk about the uterine tubes for a moment. These are going to be long, relatively long, about 13 centimeters, hollow structures. They're going to be lined by ciliated epithelium. Those cilia are going to help push the egg and the embryo down through this tube. And at the distal end is connected to the uterus. There is an infundibulum that is a generic term for a very narrow structure. So it's a funnel-like structure. And there are, at the very end of the uterine tube, fimbriae. Fimbriae are finger-like projections, and they're going to extend into the pelvic cavity and drape over the ovary, but do not come in direct contact, so that when the egg is released, it is hopefully swept up into those fimbriae, and those cilia are kind of drawing it in and moving it down the tube. There is a large ampulla region. This is a larger area where typically fertilization occurs. There are more sperm in this ampulla area. And then finally the isthmus is a short segment connected to the uterine wall. Now the oocyte is going to be transported again by the ciliary movement and some peristaltic muscle contractions of the uterine tube. And it takes a few days for an oocyte to travel down from the infundibulum to the uterine cavity. So it's a reasonable day, 3 or 4 or 5 day journey to get from the ruptured ovary down through the fallopian tube to get to the uterus. Now fertilization must occur within the first 24 hours after ovulation. The egg is only viable for that first 24 hours. Now what does that mean as far as a fertile window? Sperm are viable for, you'll hear usually 72 hours, 3 days. So that means that sperm either had to be introduced into the ampulla of the fallopian tube up to 3 days before ovulation or within a day of ovulation. So there's really about a 3 to 4 day window for fertilization. And this is that perfect timing for sperm and egg to meet. Now, the uterus, is a hollow muscular organ. It is relatively small and relatively thin when it's not carrying, but during pregnancy it does get much thicker, much more muscular. It's going to provide mechanical protection, nutritional support, and waste removal for an embryo. And remember that embryo is the first couple of months, the first 8 weeks or so. After that, we refer to the embryo as a fetus. Now, the uterus will get thicker and thicker during pregnancy and will be much thicker for contractions for childbirth. There's 3 layers of the uterus. You're not surprised by this. The prefixes tell us all about it. The perimetrium is the outer layer around the uterus. The uterus is incompletely surrounded by a serous membrane. So if you look at the overall diagram, you'll see that a part of the uterus is surrounded by a serosa, by a serous membrane, but not entirely. The myometrium is the thick layer that will contract during childbirth, and the endometrium is the epithelial lining of the inside of the uterus, and there are lots of glands in this lining. And some women will have endometriosis, which is an abnormal inflammatory response of this endometrial layer. The uterine cavity, or the lumen, the open space within the uterus, is quite large and is continuous with the isthmus. There is an internal os. This means an opening or a mouth-like structure. This is where the uterine cavity will connect to the cervical canal. The cervical canal is going to be that constricted neck-like region at the inferior end of the uterus, and then the external os will then curve into the vaginal opening. So let's put this in a picture form. We'll go in the same order in which we were discussing it. So we have the ovary. It's attached to the uterus through the ovarian ligament. Here are those fimbriae, and the egg will be released and will be drawn up into the uterine tube. The area here that's coming down is called the infundibulum. The ampulla, the top portion here, is usually where fertilization happens, ideally, and then the isthmus is the more narrow region. We see it connects into the uterine wall. Of course, there would be another matching pair over here. And when we come down, we see lots of vascular structures going to the muscle. Here's the vagina. Here's the cervix. 3 layers of the uterus: inside layer, endometrium; muscle layer, myometrium; outer layer, perimetrium. The uterus has regions, just like the stomach, similar in that there's a fundus. That's the rounded superior portion of it that where the uterine tubes dump into the uterus. There is the body, the largest portion of it, and then it constricts down toward the os, and then the cervix is that narrow neck-like region that projects into the vagina. So again, fundus, the dome, the dome-like region, the majority of it's the body, and then the cervix. Let's talk about the vascular arrangement for the uterus. So there is blood flow to the uterine artery. This is going to go up to the arcuate arteries. Now, just like in the kidney, there's an arc. There's a rounded edge to these arteries. They're going to encircle the entire endometrium. Then there are going to be radial arteries that are going to supply the endometrium itself. You'll then see some straight arteries on the diagram. These are going to go to the basilar zone. This is the region adjacent to the myometrium, and finally to the spiral arteries. Now, the spiral arteries we'll talk more about. These are going to be, quote, in the functional zone, and these are the arteries that are going to be leading to menstrual flow as they are released and destroyed during menses. So as you can see, there is the uterine artery that's coming in, and then we have the arcuate arteries. They're going to be coming in at this arc, and then these little tiny squiggly guys, now you're in the endometrium. This is what I really want to focus on. These are the spiral arteries, and they will be sloughed off as part of the menstrual cycle. So these little spiral arteries going up, and they're along the uterine glands. This is all endometrium in the pinkish area. So you can see the straight arteries coming straight up, and then you can see this little basilar zone and these spiral arteries. Now, the uterus is going to have the menstrual cycle going within it, or the uterine cycle. You'll hear it called both. And this is going to be a monthly change in response to the sex hormone levels. This is very cyclic, with an average of 28 days. So I'll be describing 28-day cycles. Keep in mind that this can range from shorter to longer cycles. The first cycle, menarche, the onset of menses, begins somewhere in the 11th to 12th year. It can be before that. It can certainly be after that. That's simply an average. And this cycle will continue until menopause, which is usually around the 50-year mark, so 45 to 55 years of age. Again, these are average ranges. This cycle can be periodically interrupted through illness, stress, starvation, and of course, pregnancy. So let's look at the phases of the uterine cycle. We'll start off with the bleeding cycle, the menses. This is the degeneration of that functional zone, including those spiral arteries. So this is going to cause a constriction of the spiral arteries. There's going to be reduced endometrial blood flow. It's going to weaken the arterial walls, and now blood will be leaving through those weakened, ruptured arterial walls. This endometrial sloughing or menstruation will last between 1 and 7 days, and there'll be about 35 to 50 mils of blood lost during this period. So again, the three layers, it's the endometrium that is sloughing off, and not all the endometrium, but the what's called the functional zone versus the basilar zone. So the basal layer does not slough off. It's only the outer, more superficial functional zone with those spiral arteries that are going to be released. Now there's also the proliferative phase. This is after bleeding, and the functional zone is going to rebuild itself. So there are some glands down in the basal layer that are going to begin to multiply and spread, restoring that lost uterine lining. It's going to be stimulated and sustained by estrogens, and those estrogens are coming from the ovaries. And this is going to rebuild that functional zone. These uterine glands are also producing a glycogen-rich mucus. Glycogen, remember, is an energy storage molecule, chains of glucose molecules, and that thick glycogen-rich mucus is also going to be nutrients for the early embryo. Recall that the egg and the sperm, when they meet, there has to be enough nutrients to provide for that embryo until after implantation and until the mother's blood supply can start to nourish the embryo through the placenta. And so there has to be a while where there's energy available to the embryo, and so it's that glycogen-rich mucus is going to assist in that early implantation. So again, we see this outer layer, the functional zone, which is what is being rebuilt during the proliferative phase. So it's going to get thicker and thicker. Then once the uterus has built back up, proliferated, then it will go into a secretory phase. The secretory phase will begin after ovulation, and this is where those uterine glands are going to enlarge. They're going to make more of those glycoproteins to help support the embryo. The arteries are going to elongate, and those spiral arteries will really begin to expand. This will be stimulated by progesterone and estrogens that are being released from the corpus luteum. So in the ovary, we refer to this as the secretory phase. Why? Because the corpus luteum is secreting hormones. Those hormones are acting on the uterus to maintain the functional zone. And this will begin, the secretory phase will begin at ovulation and be going on until menses begins once again. So during secretory phase, you can see that if you were to compare this picture, you can see that the functional zone is much, much thicker. And you can see a lot of these with squiggles in here. And those squiggles represent those spiral arteries. Moving down to the vagina, this of course is an elastic muscular tube. It is going to extend from the cervix to the vestibule. Again, that vestibule term we've seen in multiple places, just an opening into or a space into the female reproductive organs. Variable in diameter, typically between 7.5 to 9 centimeters long. The purpose of the vagina is multifunctional. One, for the passageway of menstrual fluids from the uterus. Two, to receive the penis during intercourse and receive the sperm, and also form the inferior portion of the birth canal. The vaginal canal, the internal passageway, is lined by non-keratinized stratified squamous. This is the same epithelium found along the anus and the oral cavity and the esophagus. There's a fornix. This is a shallow recess in the vagina surrounded by the tip of the cervix. You'll see that in a moment. And then rugae are formed along the vaginal lining when relaxed. So these rugae are similar to the rugae of the stomach in that there's just this wrinkled appearance. There's also a hymen. The hymen is an elastic epithelial fold that partially blocks the entrance to the vagina. It's frequently absent, but when it is present, can be stretched or torn during intercourse or tampon use or heavy physical exercise. And oftentimes, if there is damage to the hymen in a young person, it is clearly evidence of some sort of sexual activity or assault. So here's the vestibule, here's the labia minor, and the vestibule, the opening into. There are, and I'll mention them in a moment, some vestibular glands. These vestibular glands are going to be releasing fluid for lubrication, and they are similar to purpose to the Cowper gland. Remember, the Cowper glands in the male were releasing pre-ejaculatory fluids. Same thing here, the greater vestibular glands are going to be releasing fluid to help with lubrication. The vaginal canal, the hymen would be a very thin layer in this area, and then the rugae, you can see the folds, the fornix, the external os, the mouth if you will, and then the cervix itself. There's also a vaginal artery and a vaginal vein, bringing blood to and from. The vulva is everything that is visible externally in the female. So in the perineum, when one spreads their legs, we can see the perineum, and that's when you see everything that's external of the genitalia. In the female, that's collectively called the vulva. So you would see the introduction into the vagina, the vestibule, and that would be surrounded on each side by the labia minor. And then there'd be lesser vestibular glands and greater vestibular glands. And again, these are activated during sexual arousal. They're releasing mucus into the vestibule and are similar to the bulbourethral glands or the Cowper glands. There's also vestibular bulbs. These are masses of erectile tissue on either side of the vaginal entrance, and these are similar in embryological origin to the corpus spongiosum. Remember, this was some of the erectile tissues in the male. And then the mons pubis is a bulge of adipose tissue deep to the skin and superficial to the pubic symphysis that is also covered by pubic hair. The clitoris projects into the vestibule, and it has erectile tissue and would be comparable to the corpus cavernosa and the corpus spongiosum. That is, it is the erectile tissues. There is a hood or a prepuce. This is similar to the part of the prepuce on the penis, and this is going to be encircling the body of the clitoris. And then the labia major, the more prominent folds of skin, are going to encircle the labia minor. And so we see a lot of homologous structures here between the male and female. Remember that the male and female reproductive systems are derived from the same tissues, they just go a different route. And so there's going to be similar structures, homologous structures in both systems. So in this image we can take a look and kind of go down the list. The vestibule, the opening into, you can see the clitoris, the hood of the clitoris. The vestibular bulbs would be along the inside. Okay, this erectile tissue along the side. The labia major, the larger folds external. The mammary glands are also a part of the female reproductive system. They're, of course, providing nourishment for milk, lactation. This is also controlled by hormones that are released by the reproductive system and by the placenta during pregnancy. The breast glands and mammary glands will develop more prominently and begin producing milk. I should say they are directly over the pectoralis major. There is a fat layer that's involved here, and there's some suspensory ligaments that are going to help support the structures of the breast. And you'll see those suspensory ligaments, they're dense bands of connective tissue going through the lobes and lobules of the breast. Then there is glandular tissue, also broken up into lobes, and then there would be secretory alveoli, little spaces, secretory, almost like when you imagine a salivary gland or a lacrimal gland or the pancreas in releasing. These two are specialized epithelial cells that are secreting milk. There is ducts from each of the lobules converging into one lactiferous duct. And this lactiferous duct is going to expand near the nipple. The nipple will have about 15 to 20 of these lactiferous sinuses opening into the body surface, and the areolar is the region around the nipple. It is going to have some sebaceous glands around it, and so there will be a different sort of sweating, if you will, from the areolar tissues, similar to pubic and axillary regions. So pectoralis major, you can see these suspensory ligaments. So the suspensory ligaments are coming from the pec major and are going through the sections of the breast, providing support. Then you can see the purple are the actual glands. You can see that they are releasing their milk, all moving toward lactiferous sinus and then out at the nipple. So let's talk about how these two cycles talk together. So what's happening in the ovary and what's happening in the uterus. And this is all going to be controlled by hormones. There's two different cycles that are working synchronously to produce proper reproductive function. So let's go through the stages and how this whole thing begins. So the ovarian cycle will begin by the release of GnRH, gonadotropin releasing hormone. This is released from the hypothalamus and is going to go to the anterior pituitary. The anterior pituitary will then release FSH and cause production of LH. This will begin the follicular phase of the ovarian cycle. So the FSH is going to stimulate secondary follicles to become tertiary follicles, and as the follicles develop, FSH levels will decline through a negative feedback. There's also going to be secretion of estrogens. There's different forms of estrogen. Estradiol is a specific type of estrogen here. And what's going to happen is that low levels of estrogen are going to inhibit luteinizing hormone. This inhibition will decrease as estrogen levels climb. And estrogen decreases the body temperature lower than during the luteal phase, during this follicular phase. The luteal phase is going to be elevated. There's going to be elevated luteinizing hormone. That makes sense, right? The luteal phase is stimulated by increased luteinizing hormone. And there's going to be a massive surge of this LH on or around day 14 at the time of ovulation. This is going to cause the completion of meiosis 1 It's going to cause the ovulation to occur, and usually about 9 hours after that peak, and begin the formation of the corpus luteum. So now we have the luteal phase beginning right after ovulation. The luteal phase is going to be predominantly controlled by the corpus luteum, which is releasing progesterone. This progesterone will travel down to the uterus and help to stimulate and maintain the endometrial development. As that progesterone levels increase, it's going to suppress the GnRH. If pregnancy does not occur, the corpus luteum will degenerate after about 12 days. Those progesterone levels will fall off, and the GnRH cycles will increase, beginning the entire cycle again back with the follicular phase. So looking at the hormones that are involved, we have from the hypothalamus GnRH. It comes down and speaks to the anterior pituitary for the release of FSH and LH. FSH is going to go down to the ovary and begin the follicular development. LH is going to be involved with higher levels of LH will go down to be involved with the initiation of the luteinizing of the luteal phase. Of course, collectively, what these hormones are doing are regulating everything to do with the formation of the follicle and also influencing what's happening in the uterus. If we put these cycles side by side, on the top, this is what's happening with gonadotropin levels. So these are the gonadotropin, you know what this word means, gonads, gonadal structures, the ovary, tropic means to influence. So FSH and LH are both influencing the gonads released by the anterior pituitary. Notice what I want you to see here is that they both spike right before ovulation. That's really all I want you to know here. Then in the ovary, what's going on? Well, during this low level, that's follicular development. And then right before ovulation, day 14, there is a spike in LH and FSH, after which we have now the corpus luteum, regressing to the corpus albicans. What hormones are being released by the ovary? Well, before ovulation, we see estrogen. Estrogen's rising. So estrogen's important for follicular development, and it will rise again right before ovulation. Then notice that it's progesterone that is the primary hormone over here in the luteal phase, and that progesterone is released by the corpus luteum. Yes, there's a second rise in estrogen, but I want you to really think for now that there's primarily estrogen before ovulation during proliferative phase and a large rise in progesterone following ovulation during the luteal phase. And then what's happening in the uterus is that during the first 5 or 6 days or so, there is the menses, the losing, or the loss of that functional zone and those spiral arteries, and then a rebuilding, a proliferation of that. And then once the ovulation occurs and the corpus luteum begins to releasing the progesterone, we see a maintenance or even a little bit of an increase, but definitely a maintaining. And you can see those spiral arteries that are developing up through the functional zone. And then all of this, right, would be lost during menses. The bottom is what's happening with basal temperature, and so you'll see that, like I mentioned, there's a little bit of a drop in temperature just before ovulation, and then a maintained rise in temperature. And some women will time their ovulation by their body temperature, knowing the ideal time for fertilization. So this is really an important table. You need to be able to appreciate this table, know the timing of it, know the names of the different phases, know what hormones are being produced by what organ and are affecting what organ. So a little bit about birth control as we finish up. Male condoms are prophylactic. They are basically going to stop the release of sperm into the vagina, and they're simply going to stop the egg and sperm from coming together. They also can be protective against sexually transmitted diseases such as syphilis, gonorrhea, HPV, and HIV. There's also the diaphragm. The diaphragm, as you know, is just any term that refers to a barrier. You can use the diaphragm with or without spermicide, and spermicide, it makes it a more reasonable birth control method. This is, again, a dome-shaped silicone cup that is going to be placed by the female and is going to cover the external os. This can be, like I said, coated with spermicidal jelly or cream, and the failure rate here is reasonable. So it's not the most perfect form of birth control, but it is effective. Oral contraceptives are going to contain estrogen and progesterone, and what they're going to do is basically trick the body. And the problem here is that with these birth control pills can lead to problems with hypertension, can be problematic for diabetics, for those with epilepsy, can lead to gallbladder disease, heart trouble, all sorts of things, acne. And there's also an increased risk in stroke for women over the age of 35. So these oral contraceptives are not without effects and need to be discussed with your physician. Progesterone-only forms of birth control, like the Depo, these are injections, and what happens is that the uterine cycles become very irregular and cease. So basically this progesterone is tricking the uterus not to be ready for implantation. The problems with this is that there can be weight gain, and after the injection stop, there can be a slow time afterwards where there's still problems with getting pregnant. So you can't just come off this and expect to get pregnant. It can happen, but not as often. And then there are also some progesterone-only pills. There's IUDs. These are loop or T-shaped structures that are put directly into the uterine cavity. What these are going to do is basically stimulate prostaglandins and irritate the uterine wall and not allow for implantation. And then there's the rhythm method, which is simply abstaining during that ovulation period. Again, you would know that from your own cycling, as well as maybe checking your body temperature. And this is a high failure rate. And so because of the irregularity of women's cycles, this is not a proven way of child planning or reproductive planning. Now there are the after pills, the Plan B pills, or the morning after pills, and what you're doing is basically taking large amounts of hormones, and it's going to prevent the ovary from releasing the oocyte for longer than usual, and can also prevent the oocyte from joining the sperm. So really what you're doing is just kind of holding off the ovulation. And so this can be somewhat effective. If an embryo was formed, it will also not allow implantation. There's also vasectomy choices for the male. That is to sever the ductus deferens, and that would stop the release of sperm through the vas deferens and into the ejaculatory duct. And failure rates very low, no disruption in sexual function, and the sperm are still being produced, simply undergoing apoptosis in the epididymis. There's also tubal ligation available for females. It's similar in that the uterine tubes are cut and tied. This is going to be done laparoscopically. It's oftentimes done after a childbirth when a family decides they've had their last child. It does require anesthesia, whereas the vasectomy is an outpatient procedure with just local. So what can go wrong? Well, we've got some reproductive system disorders, benign prostatic hypertrophy, BPH. This is going to happen in men typically over the age of 50. It's because of a declining in testosterone production and maybe the presence of estrogen, because men are making estrogen. The decreased testosterone, the increased estrogen can lead to a increased size in the prostate. This can constrict the urethra and affect urination. The second most common form of cancerous death in males is prostate cancer. It needs to be screened by PSA. It's not horribly reliable, but still it's a part of most checkups, and treatment is removal or radiation. So you can see now the location of the rectum and the anus to the prostate, so for physical examination to feel if it's enlarging, and of course the urethra passes right through the prostate, so if this is enlarging, it can constrict flow. Testicular cancer, most common form in younger males, 15 to 35 years old, relatively low. Cancer is really rather rare in younger people, and typically this is caused from abnormal spermatocytes or spermatogonia that become cancerous. This one's pretty highly treated as long as it's caught early, and it's going to be a combination of the removal of the testis and chemotherapy. Breast disorders, there can be cysts. These are going to be fibrotic scar tissue that can wall off a portion of the breast. This is discrete masses that can be felt. This is a benign condition. Of course, that mass would not be cancerous and may need to be removed, but is oftentimes confused initially as breast cancer. Breast cancer is a malignant metastasizing tumor of the mammary gland, common leading cause of death in women, younger women, and more common in older. It's important for family history to be known, and it's important to be checked often. It has a higher rate in those with a family history and those whose first pregnancy is after the age of 30, and those with very early menarche or late menopause. So again, anything kind of extreme seems to be a risk factor. It's going to be treated with chemo, hormones, radiation, surgery, all the above, and is unfortunately rather common. Ovarian cancer, third most common reproductive cancer, but most dangerous because it's randomly or rarely diagnosed early. This is the problem with ovarian cancer, whereas breast cancer, one can feel the lumps. Testicular cancer, you can feel the lumps. There's really no signs until it has obviously spread, and this is about a 1 in 70 chance of developing during a female's life. So it's not as common as breast cancer, but certainly not terribly rare. The problem is that, like I said, it's already spread, and the prognosis can be poor if it's not caught early. Cervical cancer, this one is screened for constantly using pap smears, and we know that HPV virus, human papillomavirus, is responsible for about 75% of cervical cancers. And so now this is why people are getting vaccinated against HPV. Yes, it's a sexually transmitted organism, but the Gardasil, for example, is also protecting and decreasing the number of cervical cancer cases. So it's not just a matter of being immunized, vaccinated against an STI, but also to decrease cervical cancer. STDs, of course, or STIs, are transferred from person to person. These are diseases that are only spread through sexual intercourse and can range from inconveniences to being lethal. And there are dozens now of bacterial, viral, and fungal infections that are considered STIs or STDs, including chlamydia, AIDS, syphilis, gonorrhea, and the list goes on. The incidence has been increasing in the country. There's always new cases of STIs. Many of them are reportable, so the CDC has fantastic data on these, and about half of the cases of STIs are in the younger ages, who are less likely to be aware of safe practices and more promiscuous. So that brings us to the end of the female and male reproductive systems. Please, please, please go into mastering and start working on the homework assignment for this chapter, and that will help you not be cramming at the end. I will be continuing on with the urinary system at our next presentation, and that will be next week.